So we've had some very lively debate at this EBMT meeting in Frankfurt around the emerging and potentially very important role of FLT3 inhibitors as a strategy to improve outcome in patients with FLT3 positive AML. Richard Stone presented the important Midostaurin data demonstrating improved survival, recently published in the New England Journal of Medicine. This study combined midostaurin with induction chemotherapy and demonstrated improved survival. This study combined midostaurin with induction chemotherapy and also delivered it as maintenance and demonstrated improved survival. There's also some really important data with Quizartinib, recently published, demonstrating that this is an effective salvage strategy as monotherapy in patients who relapse after chemotherapy and high CR rates, and certainly better CR rates than were observed with intensive salvage chemotherapy. And the other really important area of debate with regard to FLT3 inhibitors is their potential role as maintenance therapy post-transplant. So we are all aware that disease relapse is the major cause of treatment failure in patients allografted for FLT3 positive AML. We're also aware that when these patients relapse, they relapse very quickly. So actually designing strategies to reduce the risk of disease relapse is very challenging. One of the most plausible approaches is to argue that the disease may relapse before a donor CD8 T cell or NK mediated graft versus leukemia effect has had time to be established post-transplant. And therefore, simply by manipulating the kinetics of relapse, simply by pushing back relapse, you may give the donor GVL response time. You may buy time for the exertion of a graft versus tumor effect. And that's one of the attractive notions of applying targeted therapy post-transplant. Interestingly, there's also new data that at least one of the FLT3 inhibitors, Sorafenib, also may have the ability to augment a graft versus tumor effect in a completely different way. There's evidence in mouse models that Sorafenib upregulates IL-15 production, and IL-15 can drive donor T-cell expansion. So this class of agents looks really interesting, and the retrospective data that's been generated to date does demonstrate improved outcomes in patients who received Sorafenib post-transplant compared with historical controls.